Anemia is when you have a limited number of red blood cells or erythrocytes, which causes a lower hemoglobin concentration. Hemoglobin is the protein responsible for transporting oxygen in the blood. When you have a limited oxygenated red blood cell circulating, you have a decreased oxygen delivery to the tissues and organs. Anemia can be classified into three separate subdivisions. Hyperproliferative anemia, which is a deficit in the production of red blood cells. Bone marrow can simply just not produce enough erythrocytes. Hemolytic anemia, which is a premature destruction of red blood cells. And then bleeding, results from blood loss, generally from the GI tract. There are different factors affecting anemia. So, when caring for a client with anemia, it's important to remember each client may present differently. It's also important to assess each patient. So, what do we want to know? At what rate did the anemia occur? Someone with acute anemia who might have had this come on rapidly, such as a trauma or a severe GI bleed, is going to be much more symptomatic with much more severe symptoms versus somebody with chronic anemia or a slower GI bleed whose symptoms may be less subtle, related to the fact that the body has been able to compensate. These patients, you might only see a slight increase in their heart rate or complain of feeling slightly fatigued. We also want to take a look at the metabolic requirements of the patients. Someone who is anemic or has had some type of blood loss and they are active will be much more symptomatic than someone who lives a sedentary lifestyle. Lastly, we want to take a look at any comorbidities the client may have. In a client with pulmonary or cardiac comorbidities, even the slightest decrease in red blood cells will have much more pronounced symptoms like chest pain, cramping, shortness of breath, muscle pain. These symptoms will be seen much sooner than someone who doesn't have any prior pulmonary or cardiac issues. As mentioned previously, hypoproliferative anemias is a result from the deficit in the production of red blood cells. This can be broken down into three separate categories: iron deficiency anemia, aplastic anemia, and megaloblastic anemia, which includes both folic acid and vitamin B12 deficiencies. Iron deficiency anemia is the most common type of anemia seen. Iron is necessary for hemoglobin synthesis. So when someone has iron deficiency anemia, the iron stores become depleted, which says they have an inadequate intake of dietary iron needed to produce hemoglobin. Most common cause is through the GI tract for GI bleeding, such as gastric ulcers, gastritis, inflammatory bowel disease, such as Crohn's or ulcerative colitis. An inadequate supplement during pregnancy can also result in iron deficiency anemia. A lot of clients who suffer from alcoholism have iron deficiency anemia due to the chronic loss from the GI tract from gastric ulcers they often suffer from, as well as an unhealthy diets and improper nutrients. We can also see this in clients who have problems with absorption of iron. This is often seen in the client who may have had part of their stomach removed or a gastrectomy, or the clients who have undergone bariatric surgery. Someone with iron deficiency anemia has all the symptoms of anemia you would expect to see, such as shortness of breath, dizziness. They might complain of chest pain, especially with exertion. They may look pale and skin tone. However, if iron deficiency anemia is left untreated, they may present with brittle nails, smooth, sore tongue, and they often complain of pica. Pica is a term used to describe the craving or chewing of substance that has no nutritional value, such as dirt, clay, paper, or ice. This is often seen in pregnancy with iron deficiency anemia that goes untreated. When we look at diagnostic findings, a bone marrow aspiration would be ideal. You would expect to find low levels or even absent levels of iron in the marrow. This, however, is very invasive, obviously. With advancements in lab studies, we're now able to diagnose based on lab findings and clinical manifestations. So someone with iron deficiency anemia, their labs will show a decrease in red blood cells as well as ferritin levels. We also would expect to see a decrease in the MCV, or the mean corpuscular volume. This looks at the volume or the size of the red blood cells. Due to the iron stores becoming diminished, the body only produces small red blood cells in the attempt to conserve as much iron as possible. It's also important to note that clients will have an increase in the TIBC, or a total iron binding capacity. This looks at the protein that is responsible for supplying the bone marrow with iron. So this is elevated because it's not being utilized within the body. Since they have low iron levels, that protein is not being used to transport the iron to the bone marrow. When we look at the medical management of iron deficiency anemia, we want to first and foremost determine the cause of the anemia. So the client will most likely undergo a colonoscopy or an endoscopy, and they're looking for things such as gastric ulcers or gastric cancers. Iron supplements are used for treatment of iron deficiency anemia and correcting them. Depending on the severity, the client may require IV iron at first, and then they'll be switched over to oral supplements. Nursing management focuses a lot on the dietary teaching, so education on iron-rich foods such as beef, liver, leafy green vegetables, certain beans, raisins. We also want to educate them on taking iron-rich foods with a source of vitamin C, which will help with the absorption of the iron. Vegetarians are at a higher risk for developing iron deficiency anemia, so we'd want to offer suggestions for them as well and potentially consult the nutritionist for guidance and support. When educating a client about their oral iron supplement, we want to encourage them to take this on an empty stomach at least 1 hour before or 2 hours after meals, as taking iron supplement with a meal can decrease the absorption to up to 50%. We also want to talk about the possible GI side effects such as nausea and vomiting or constipation. If a client is suffering from constipation, they may need to take a daily stool softener or we can educate them on increasing a higher fiber foods into their daily diet. We also want to educate them on the fact that their stools may be darker in color and that this is an expected finding to see. As mentioned previously, we want them to take the medicine on an empty stomach. However, some clients can just simply not tolerate it due to gastric difficulties. If this is the case, they will have to take it with a meal. But we want to definitely stress the importance of not taking the medication with any dairy products, as this greatly affects the absorption. There is also a liquid form of iron, and some clients will choose to take the liquid as it tends to have a little bit of a decrease in the gastric distress than the tablet form. If they are going to choose to do this, it's important to educate them on the use of a straw and being sure that they rinse their mouth after to help prevent teeth staining. Aplastic anemia is a very rare condition in which there is a decreased output or a damage in the bone marrow stem cells. The T cells within the body, which are a subtype of white blood cells, start attacking the own cells of the own bone marrow. This attack on itself causes the bone marrow to be replaced with fat. This results in hemopoiesis, which is the formation of blood. So not only will a client with aplastic anemia have a decrease in their red blood cells, we will also see a significant decrease in platelets as well as white blood cells within the body. They have found that things such as viral infections or pregnancies can trigger the onset of aplastic anemia, but most are idiopathic or without any apparent cause. The clinical manifestations of aplastic anemia are usually very gradual and subtle. Due to a decrease in all types of blood in the client, will present with anemia symptoms such as shortness of breath, pallor, fatigue. They may also present with retinal hemorrhage from a decrease in platelet production. A client with aplastic anemia is at very high risk for infection due to the decrease in white blood cell count. This is often seen in throat infections. As a nurse, we will want to continuously monitor for signs and symptoms of infection, as this can be very detrimental for the client's well-being. Purpura is bruising or bleeding which develops under the skin. This is often seen in the later stages of the disease. Since these symptoms present gradually, the client often seeks medical attention for simply not feeling right, maybe having frequent infections or feeling fatigue or notice some increased bruising. Most often, the provider will start by ordering some blood work, such as a CBC. If a CBC is ordered for these patients, it will reveal pancytopenia for the client, which will be a greatly decreased value in the client's neutrophils, hemoglobin, and platelet count. The client would then most likely undergo a bone marrow aspiration, which would show very few red blood cells in the bone marrow and also show that the bone marrow has been replaced with fat. As far as medical management, depending on the client's health status, if they are healthy enough and a donor can be found, these clients will undergo a stem cell transplant. By successfully undergoing a stem cell transplant, these clients are considered cured of the disease. If a stem cell transplant is not an option or a donor cannot be found, a client will go on immunosuppressants. These immunosuppressants will prevent lymphocytes from destroying the stem cells. A common immunosuppressant used in aplastic anemia is cyclosporins. Clients may also receive supportive therapy such as red blood cell transfusion or platelet transfusions when needed. As far as nursing management, we want to monitor for side effects of the immunosuppressant, also being mindful of kidney or liver dysfunction. We want to educate the client on the importance of following up with routine blood work to monitor the kidney and liver functions. We also want to continually monitor these patients for signs and symptoms of infection. As mentioned previously, unfortunately, a majority of the patients with aplastic anemia who die will die secondary to some type of bacterial or fungal infection that they have acquired and their body was unable to fight off. Vitamin B12 and folic acid are both necessary for the formation of red blood cells. When a client has megaloblastic anemia, they have a deficiency in either one or both of these vitamins. Deficiencies in either vitamin B12 or folic acid causes bone marrow changes, leading to erythrocytes that are produced being abnormally large. We also see changes in other blood subtypes such as leukocytes or platelets, which may be affected by being abnormally large in size as well. So what we end up seeing is an increase in their production rate of their abnormally large erythrocytes, platelets, and leukocytes. However, most of these abnormal cells are destroyed within the bone marrow and never actually make it to the circulatory system. The only cells that actually make it out of the bone marrow are the mature red blood cells, platelets, and leukocytes. However, there is a very small amount in the circulatory system, leading to pancytopenia. Megaloblastic anemia tends to develop very slowly, so oftentimes in the early stages, the patients are asymptomatic due to their bodies being able to compensate. Unlike an iron deficiency anemia with an MCV lab test revealing a below average, someone with megaloblastic anemia may have an elevated MCV lab count, which, as mentioned previously, the MCV measures the size or volume of the red blood cells. So due to abnormally large size in these red blood cells, the MCV lab value would be expected to be elevated. The main cause of someone with folic acid deficiency is usually due to diet deficiency. The body is only able to store a very small amount of folic acid. So after a few months of a dietary deficiency, the amount of folic acid within the body becomes depleted. The most common food source for folic acid is green vegetables. We will also see folic acid deficiency in our clients who suffer from alcoholism due to the fact that alcohol increases folic acid requirements, and also these clients tend to have a diet deficient in this vitamin. We may also see this in a client with malabsorption disease such as celiac disease. And just like iron deficiency anemia, someone without proper prenatal care may end up with a folic acid deficiency as an individual requirement increases during pregnancy. When we take a look at a vitamin B12 deficiency, this is rarely due to a diet issue. Most commonly, this is seen in clients who may have an absorption issue within their GI tract. For example, we will see this a lot with our inflammatory bowel disease clients, such as Crohn's, especially if they've undergone some sort of bowel resection, with our bariatric clients or clients who have undergone a gastrectomy. Certain medications such as metformin or our PPIs that help reduce the gastric acid production can also inhibit B12 absorption. We might also see a vitamin B12 deficiency when a client has what we call pernicious anemia. This means they have the absence of an intrinsic factor. The intrinsic factor is secreted by the cells within the gastric mucosa, which enables the body to absorb vitamin B12 into the small intestine. So what happens is this intrinsic factor binds with the vitamin B12 and carries it into the small bowel. Without the intrinsic factor, vitamin B12 cannot be adequately absorbed. When looking at the clinical manifestations of both folic acid and vitamin B12 deficiency, they're very similar. They both present with what we would expect to see with someone who is anemic. The biggest difference in someone with a vitamin B12 deficiency is that they may present with neurological complications such as confusion, numbness and tingling in their extremities, weakness, gait disturbance. Both folic acid and vitamin B12 can be measured using serum lab testing. The Schilling's test used to be the classic test to diagnose vitamin B12 deficiency. However, due to limited availability and the cost, this is not used as often. Most commonly used now to diagnose someone with a vitamin B12 deficiency due to pernicious anemia is to undergo an intrinsic factor antibody test. If the test is positive, it indicates that someone has pernicious anemia, as the antibodies inhibit the absorption of the vitamin B12. When looking at the medical management for someone with a folic acid deficiency, it's usually related to a dietary deficiency. A lot of our management would be placed on dietary teaching, educated on foods high in folic acid such as greens, vegetables, beans, spinach, orange juice. They may also be started on an oral folic acid supplement, usually 1 gram a day. Treatment of vitamin B12 deficiency depends on really the cause of the deficiency, if it's due to pernicious anemia, the client will be started on a monthly IM vitamin B12 injection. Due to the lack of the intrinsic factor, there would be no point in giving these clients oral supplements because they would not be able to absorb them in the GI tract. As mentioned previously, hemolytic anemia results from the premature destruction of the red blood cells. When this occurs, the lifespan of the erythrocytes is shortened, leading to a decrease in the amount of red blood cells in the circulatory system. With a decrease in the number of erythrocytes in the body, a client often suffers from hypoxia. So what happens is the low levels of O2 stimulates the kidneys to increase the erythropoietin, which causes the bone marrow to compensate by releasing premature red blood cells, also known as reticulocytes. So if we were to look at the client's lab values with hemolytic anemia, we would see an increase in reticulocyte count as well as a bilirubin count. This is related to the high destruction of red blood cells, as we know the heme on the red blood cells breaks down bilirubin. Sickle cell anemia is an inherited anemia and one of the most severe and common hemolytic anemias we see. When a client with sickle cell anemia inherits the sickle hemoglobin gene, this causes the hemoglobin molecule to be defective. So what happens is a client with the sickle cell is exposed to oxygen tension. The normal round pliable shape of their red blood cells becomes very rigid, dehydrated, and forms that sickle shape as shown on the slide above. One of the major concerns that we worry about with these clients is when these cells take that sickle shape, they are at very high risk for getting clumped together or stuck together within the blood vessels, which leads to ischemia or infarction. This is an intermittent process, and with quick medical intervention, the cells can go back to their original round and pliable shape before any damage occurs within the body. As you know, the normal lifespan of a red blood cell is about 3 months or 90 days. However, someone with sickle cell anemia, the average lifespan of their red blood cells is about 10 to 20 days. Looking at the clinical manifestations, these clients will present with signs and symptoms of anemia. They may also be jaundiced from the rapid continuous breakdown of their red blood cells. They may also have tachycardia from chronic anemia or chronic hypoxia. This chronic tachycardia can lead to an enlargement of the heart, ultimately leading to heart failure. In an effort to compensate, we may see enlargement in bones, particularly the skull and the face. Clients with sickle cell anemia are at an extremely high risk for development of a thrombosis, especially when they're in the middle of a crisis because the sickled cells can clump together within the blood vessels. The most common organs that we see this in are the spleen, the lungs, and the central nervous system. This is due to the fact that these areas in the body tend to have a slower circulation through them, so they're at higher risk for developing thrombosis. As the blood slowly moves through these organs, it can easily stick together. Due to the increased pulmonary pressure, or since the client is at high risk for infarction, they're also at an increased risk for developing pulmonary hypertension. When the client has a flare or enters into a sickle cell crisis, as you'll hear it called, there are 3 main subtypes you will see. However, you guys will not be responsible for knowing the 3 subtypes. When looking at the management of sickle cell anemia, if a client was to undergo a stem cell transplant, this would be considered a cure for their disease. However, issues may arise when trying to find a compatible donor, or a client may be ineligible for a transplant due to severe organ damage that may have already occurred. As far as pharmacological therapy, hydroxyurea is a chemotherapy agent that has been found to be effective in helping patients with sickle cell. This medication works by increasing the fetal hemoglobin levels in a patient, also decreasing the formation of those sickled cells. Red blood cells with higher levels of fetal hemoglobin protein are less likely to sickle. Major side effects of this medication is the suppression of the leukocyte formation. The client may also undergo frequent blood transfusion depending on the severity of their disease and the clinical manifestations presented. As far as supportive management when caring for a client during a sickle cell crisis, the emphasis is put on pain management. These clients tend to complain of excruciating pain. The pain is generally what causes them to seek medical treatment and come to the emergency department. During a crisis, the client may be given an aspirin as well. This will help to help with the pain and may also help decrease inflammation and decrease the risk for those potential thrombosis, since we know aspirin can help with the platelet aggregation. During an acute crisis, patients are often treated with IV analgesics such as morphine or Dilaudid. We also want to encourage the use of non-pharmacological agents such as heat, distraction, and massage. This is also going to be patient-specific on what interventions help them. It is extremely important during a crisis to keep these clients hydrated. If the crisis is caught early enough, often these clients can be treated with oral hydration. But the majority of the time in the hospital setting, we will often see some kind of IV hydration ordered. Oxygen may also may be needed if the client is complaining of shortness of breath or having a decreased perfusion throughout the body. When determining our plan of care for these clients, we want to keep in mind these clients are often very fatigued due to the hypoxia that occurs during the crisis. So it's really important to create an organized plan of care for these clients so we can provide them with the necessary interventions, but also allow them time for rest and sleep. As far as the nursing management, we're continuously assessing the different body systems of these clients. We would want to closely monitor for any abdominal pain, fever, signs of infection, as this could indicate a splenic infarction, as we know the spleen is one of the primary sites for the sickling cells to occur and clump together. In addition to what I mentioned before, we will continuously monitor these clients for signs of lung infection, skin ulcers, or osteomyelitis. These clients would also have a decrease in their wound healing. Dehydration or acute kidney injury may occur from sickling of the cells within the renal medulla. A lot of education goes into caring for clients with sickle cell. Encouraging the clients to stay well hydrated and prevent any cold environments will help prevent vasoconstriction and can also be effective in diminishing the severity as well as the frequency of these attacks. In addition to managing the client's pain with medication, they also may present with swollen joints. So we want to encourage them to elevate those joints until the swelling diminishes. Due to the fact that erythropoietin is produced mainly in the kidneys, there is a very strong correlation with somebody who has chronic kidney disease and anemia. As a client's renal function decreases, so does the erythropoietin production, leading to a decreased production in red blood cells. We can also see folic acid deficiency in someone with chronic renal failure, especially when undergoing dialysis, since the folic acid passes through the dialysate during dialysis. In this case, the client may have to take an oral folic acid replacement.